Bob Phillips, welcome. Thank you so much for joining us today. I need your help. I've been trying to explain, understand myself this whole issue of comparing clinicians, comparing clinics, comparing institutions, just this whole comparing business. And it seems like nobody likes to be compared unless they feel like they're better to start with. So it's a dicey business, this comparing. And when the biggest thing I hear when we look at comparison is it's not fair. It's not apples to apples. I'm different, which is true. And so anyway, so let's just jump right in. Tell us about yourself and how you're connected to these issues.
So
I'll
tell
kick
us
it
your
off.
connection to this work.
Danny, I'm a practicing family physician. I have been now for 25 years, but most of my time is spent at the Center for Professionalism and Value in Healthcare, where we're really trying to align how health professionals are measured and what are the quality measures used to gauge whether you're a good doctor or a bad doctor. We're trying to align that with the things that we do that actually provide good care and the things that we value and patients value. And I'm in this space because I know that alignment is important to reducing burnout for clinicians and actually for delivering good care. And I've seen that in my own practice for a long time. The things that we work at really hard to get good scores on are not actually the things that we do that help patients the most.
So
For example, in primary care, we have really good evidence that continuity, that having a trusted healing relationship with a primary care clinician has good outcomes over time. And yet we destroy that when we try and maximize access, try to make sure that any patient who wants to get care gets that care as soon as they can. And while you would think that's important too, what that really is about is keeping my schedule full so that we can maximize our dollars per hour. And that gets right in the way of making sure that someone gets to see me when they need to see me because we've been together for a long time. And that's not always valued by young people who don't have a lot of health issues, but as we get older or if we have chronic health conditions, having the same person often means that things will turn out better.
so
And
you like saying that sometimes there's tension between different ways of measuring quality, access versus continuity.
there absolutely is a tension there, and both are important. Someone should be able to be seen soon, and someone should be able to see someone they need to see. And those are in tension because one of them has an economic engine attached to it. And that practice or the health system's incentive is to make sure my schedule stays full.
Okay.
But it's not just attention. If that fundamental measure that's so important in primary care is not made high value, it means that I'm just getting churn. I'm just seeing different people all the time and I have no relationships with them. It's harder for me to learn what they've been through, what their priorities are, what their values are, what they're scared of. And it's hard for me to change their behavior because it's hard for me to relate to them on a personal level when it's just a transaction.
Okay.
So that's one example of a really high value measure that doesn't get measured because it is intention and because we have 100 other measures that we're trying to work to every day. We just published a paper with Larry Castellino at Columbia University last month that showed that physicians who have higher quality measures based on disease measures are more likely to be burned out.
Oh, really? Oh,
Yeah,
that's interesting.
at least emotionally exhausted. If they get all the way to being callous, meaning they just stop caring, then that falls off. But they're burned out because they're working so hard to maximize these quality scores, and it's not what they want. It's not what they want to be doing, and it's not what they think patients need.
Okay.
So they're expending so much time and effort to just check boxes, and it gets in the way of good care.
So check boxes like immunization.
Yeah, like my patients coming in for anxiety and they're going through a divorce and they really need someone to help them manage that problem. But I've over here, I've got a list that says, "Oh, you haven't had a colonoscopy this year. Oh gosh, and you're diabetic and your A1C score is too high and your blood pressure is up." And it's so distracting to have to
Mhm.
work at those when those aren't the patient's priority today. And it's not what I should be doing today to make them feel better and actually be better.
Okay. So if we're, I'm trying to think about this from the public's point of view.
Hmm.
So I have MS, primary care and neurology. Those are my primary or my most important clinicians. And when my neurologist left town and I needed a new neurologist, had no idea how to use publicly available data to compare one to the other. I knew what was important to me. They needed to use the portal. They couldn't be intimidated by me as an engaged patient. Those are the two probably really important things that are not in measurement.
No, that's right. That's right.
I'm a member of NQF. I'm on different NQF panels, and I look at the National Quality Forum, NQF,
Yeah.
and I I look at what they're measuring, and I can't imagine using those to decide where to get care when I have the luxury of a few minutes to think about it, as opposed to when I need to go to the ER and
Yeah.
something's a crisis. So how does this whole measure to compare line up with what people might use to decide where to get care?
So that's a great question, Danny. So you can go to medicare.gov and pull up what used to be called Physician Compare, which is actually hard to find these days. It's now called Care Compare.
Okay.
And you can look up a health system or you can look up a clinician. And for the measures that they have, you can compare physicians. But I'm not sure if you do that, that it's actually going to be very useful. And that's the shame of it, because that's what this is supposed to do. It's supposed to give
Right.
you as a patient, yeah, the way to differentiate. Should I go to this doctor or this doctor?
Or for
Um,
my mother, I'm a caregiver, and for them. So, not just for me, for my family.
and you'd like to have something better than Yelp for physicians, right?
Yeah.
But gosh, if you put into any search engine the name of a physician, you'll get 8 different things that are ranking that physician based on patient reported data. And unfortunately, that's what most people have to rely on, unless they're fortunate like you to have a primary care doc who might be able to say, I really recommend this neurologist.
Yes, yes, that is big. And I found a urologist that my neurologist recommended, and my primary care doc was really interested that I liked her. I liked the urologist.
Yeah.
So that she added that information in her recommending to other people. She's like hungry for feedback. And if she refers somebody, she'll ask me, what was your experience? Was that a good referral? So yeah, and I trust her, my PCP. When she sends me to somebody, it's more likely than not
Yeah.
that it's a good referral.
So I would say I think that this ability to compare physicians on quality is that it's not a bad idea. It is certainly in its infancy. Um,
Yeah.
it's far from baked. And I think the processes we've set up, like the National Quality Forum, where patients are supposed to have a voice, and I'm so glad you're there, or CMS's endorsement process, which is driven by National Quality Forum, but not entirely. It's just not quite got it right yet. And it's why we have worked on what we call measures that matter. And we're trying to come up with a very small bucket of measures that are very important to patients, very important to clinicians, and are related to quality of life and costs. And so we have continuity right at the top. It's already endorsed by NQF and it's in the process for CMS. We have comprehensiveness, the ability of a primary care doc to deliver most of the care that a patient needs, or at least to guide their care, people that they trust. We have a measure it's a patient reported measure called the person-centered primary care measure that was developed by patients and clinicians and payers 11 questions that are from the patient's voice about the quality of the care and the quality of the relationship that they have with their clinician. And then we're working on 2 others that are still exploratory. One is around total cost of care. It does to patients, certainly. And in primary care, it turns out it is really continuity and comprehensiveness, how much they keep you from going on to having unnecessary costly care. And then the last one is trust.
Yeah,
Um,
trust.
we developed measures of trust 20 years ago, but we never implemented them.
Okay.
We're now going to be testing those with patients to see how they relate to other quality measures.
Oh, there's so much in what you're saying. Let's take the last one first, trust.
Yeah.
I often compare like all the decisions that I have to make as a person with a chronic progressive illness. It's like putting in a kitchen. There's so many decisions to make, and there's certain decisions that I want to reserve for myself. Like I don't want to mess with my pathological optimism. I don't want to hurt myself. I want to keep playing my saxophone. These are things that are important to me. The rest of it, I want to trust my clinicians. Like I don't understand why I take $100,000 infusion for my MS. And I'm a smart person. And he's explained it to me like 5 times. And I still don't quite understand it. But he thinks I should do it. So I do it. And I feel like I need to trust so that I don't have to make all these decisions because it's exhausting. So go to the cost one.
Yeah.
The part of that is just having some transparency about it. That it seems like it more and more is out of pocket. And so for people who are privileged like I am, who have a Medicare Advantage program that really pays for quite a bit, there's still each year there's more out of my pocket. And yeah, and that is such a hard conversation because people don't know.
And that's improved over the last couple of years with some of the transparency that hospitals have to have about what it costs to have a procedure done. So you can actually look that up now. I had a hernia repair in October of 2020 before that law went into effect. And my initial charge for the hernia repair was $55,000.
Oh my God.
And discounted for my out-of-network plan, it was $33,000. It was ridiculous. Now, if you look at the cost of that procedure on the hospital website, it says $7,500.
Oh my goodness.
So the transparency requirements now by law, I think are going to drive down prices and allow patients to compare hospitals on things. And I think that's really important. But even upstream of that, I had a hernia, it needed to be repaired. But there's a lot of care that happens that doesn't need to happen. There's a lot of MRIs for headaches out of the gate before we've ruled out other things. There's just a lot of procedures done. I have a patient with what now turns out to be long COVID, but was a lot more short of breath than usual, which is often a trigger of concern for having heart disease. And he's a 60-year-old gentleman, new onset of shortness of breath. And he went through the full workup before he got back to me. And I just started, it was all normal, thank goodness, but I started working backwards from that symptom. And the cluster of symptoms he had were just classic for long COVID. And had I known that ahead of time, I probably could have spared him some of that treatment, some of that investigation. And it's that kind of having that kind of relationship, that prior knowledge of a patient, that trust that lets you protect them from downstream costs. And the other reason that's important, Danny, is because it's not just downstream costs. It's sometimes those things are harmful.
Yeah.
Sometimes those investigations can cause problems.
Yeah.
And that's my job. And I can't do it very well if someone doesn't know me and trust me.
Yeah. Another thing that I've tried on my podcast to explain and haven't done a very good job of is risk adjustment. And I was on an NQF panel about risk adjustment, and I can't say that I came out of the panel understanding any more than I went in, which is really how I found you, because I went to Bill Lawrence at Picori and
Yeah.
said, I need somebody to talk to. And he recommended you. And I know that when I look it up, it says risk adjustment is a statistical process that takes into account the underlying health status and health spending of the enrollees in an insurance plan when looking at their healthcare outcomes or healthcare costs.
Yeah.
But it really seems to me that I know enough about statistics to be dangerous. And I know that when you like adjust things, that you're diluting something. So if you're going to average something that happens to a 2-year-old and a 90-year-old, and you get a 44-year-old, you're not really looking at anything of use. So, like in your work, how can we better understand what it is, what risk adjustment is, and why it's important and what it does for us?
So risk adjustment, so it's not a 2-year-old and a 90-year-old, and now you get a 44-year-old or 45-year-old. It's if my panel of patients is more complex than another physician's panel of patients, and my quality score is lower than that person's, if you don't adjust my quality score, you may think I'm a worse doctor. When I'm in reality, given the complexity of the patients I take care of, I may actually be doing a better job.
Okay.
So risk adjustment is largely to make sure that we're comparing apples to apples when you're making a decision. Do I pay this physician more or less because they're doing a better or worse job? From that point, it makes sense. Where it gets lost a bit is when I'm in control of my risk score. And that's driven because it's driven by how many diagnoses I put down for every one of my patients and how many
Okay.
diseases I say they have. And it's not to say that anyone's committing fraud, but it certainly creates an incentive for me to maximize and capture everything I can that makes that person look complex. And so you wind up with some plans who do that exceptionally well. There are electronic health records that have that as an app on them. So some places get scored very well or paid very well compared to someone else. And it's not really because they're taking care of more complex patients. They just do a better job of capturing all those diagnoses. And that's unfair. And for some of our Medicare Advantage plans, they've been criticized because it just pulls so much money out of the Medicare trust fund that it's going to go bankrupt sooner because their panels are risk adjusted to being very complex and they get more dollars for that reason. So it is troubled.
But it seems like risk adjustment has to use certain data to
Yep.
decide. And you're talking about one feature, which is complexity, and
Mhm.
complexity as number of diagnoses.
And
But it
and
could
the,
be that complexity is availability of transportation. It's harder for them to get to the doctor. That's the complexity, but that's not
yeah,
anywhere in the numbers.
it is not currently. You are absolutely right. So people may have different social issues that make their care outcomes worse, and that should be in the risk adjustment too. So let me differentiate risk adjustment for payment,
Okay.
risk adjustment of quality measures.
Oh, okay.
Those are,
Okay. Yes. Go ahead. Yeah.
yeah,
Yeah.
so those are two different things. So we've been working very hard on the risk adjustment for payment because we are underpaying clinics that take care of people from poor neighborhoods, people from rural areas, because like you said, those people lack some fundamental things like housing stability or food security or transportation. And those things affect their health far more than their diseases. So we've been working at creating a new way to adjust payments and take into account those things and to avoid the gaming problem that has been revealed for diagnoses. We've focused on using your neighborhood.
Okay. So, like a zip code?
Yeah, or even
Oh, okay.
smaller than zip code. So census tracts in particular are usually about 2,000 homes, and they're designed to be more like that. All the people living in there are more like other people living there than people in a different census tract.
Okay.
And based on your census tract, the poverty level, the unemployment level, the home ownership, a single family household, education level, all of those things roll up to a risk score. We can demonstrate those things are related to your how long you live, whether you're likely to have a disease like diabetes, whether you're likely to show up in an emergency room. And we can use those to adjust payments so that the clinic taking care of the people in that neighborhood get more resources to help with housing, food,
Mm.
transportation. So that's
Oh,
the
that's
risk
okay.
adjustment on that side.
That's interesting. I hadn't heard it explained like that before. That's helpful. So what do you think we should have talked about that we haven't related to comparing and risk adjustment measures?
That second bucket of risk adjustment for quality measures, Danny,
Okay.
is the one that everyone's wrestling with, because if you start using those social risk adjustments for neighborhoods, what some people are concerned about is that you'll be hiding poor care for poor people.
Uh-huh.
Some of us have argued back that's not the purpose of risk adjusting the quality measures. It is so that you can understand, based on the social risks of that neighborhood, are we actually providing better care than it looks like we are? And while we could be doing better, we probably need more resources to achieve that.
Yeah.
And if you give more money based on social risk on one hand, and you take away money as a penalty because of quality scores on the other, in the end, the balance is that clinic may not get any more resources than they did before. And so we need to pay them more, and then we need to know, are they doing better or worse than they should be based on that population? And that's how we're trying to balance.
One of the things that's weird about measures is that they seem like they're point in time rather than, to me, the purpose of measuring is to see I took an action, is it working? And so it's like how it changes over time. How
Yes.
does, and is that like part of the deal?
So that is a fantastic question. The problem is that we're in such our measure efforts are such infancy that we can't yet do that on the measure side.
Okay.
But we're not just in the measure business at my center. We're also part of a certifying board, and that is the
Okay.
role of certifying boards, is to help our docs, our family physicians, know where am I now, and what can I do to get better,
Yeah.
and did I get better? That's part of certification. And that's why the certifying boards and the measures world, like CMS, need to work together to know where people are at point in time, but then to help them improve and demonstrate it.
So
And
is a certifying board like Joint Commission and NCQA, or is it different?
so Joint Commission works that way for hospitals. Certifying boards tend to function that way for physician specialties. So we certify family docs. There's another board for general internists. There's another one for pediatricians.
Okay.
Those boards should be working collaboratively with the measure world to build better measures, which is what we're trying to do, but also to come up with ways to help them improve.
Wow. Well, a lot of food for thought here. I appreciate this. Thank you for your time. I have to chew on it.
I'm grateful to you for helping me think about how people outside of my world understand this. And as you chew on it, if you think of better ways for us to talk about it, I'm happy to come back, Danny.
That's great. Thank you.